Thank you, Brett, and thanks for having me here today. I notice that there's a lot of breadth in the audience, so I may not be able to touch on something that's passionate to all of you, but we'll see how we go. So as Brett said, Greg Williams, I'm from the CSIRO Futures team. We're essentially a boutique consultancy that sits within CSIRO, but does work for external clients, be it Australian governments or large Australian businesses. What we do, we draw on the deep domain expertise of our 5,000 plus researchers, technologists, to help our clients better understand the potential futures that their sectors are facing, and more importantly, the role that science and technology can play in preparing for the opportunities and risks that could fall out of any of those futures. Creating the healthiest nation through addressing inequity. It's an ambitious goal. It's not an impossible goal, but it's certainly an ambitious one. CSIRO's CEO, Larry Marshall, has stated a goal for CSIRO to help Australia become the healthiest nation on earth. Similarly, the Australian government's got a similar goal. Nobody's really spoken about what metrics will be used to measure that goal. But despite that, I'm very happy to see it put up there as a goal for the nation. And with all of Australia's health system issues, and there are many, comparatively, globally, we are actually quite a strong nation in terms of health outcomes. We rank top 5 on most metrics that people like to report, and that's not just life expectancy, that can be a somewhat crude measure of health, but for example, Australia's health system's noted as one of the most efficient and equitable in the world on Bloomberg's Healthy Country Index, where we rank, again, number 5 of 163 countries. So yes, there are absolutely areas we need to improve on, and no doubt we'll get to all of those today, but I think it's important to just start with the message of we're doing our best. There's a long way to go, but comparatively, nobody is really smashing this issue out of the park. It's really complex. It's not a new issue. People have been struggling with it for a while, and we've got a relatively good foundation to work from. So first, just a little bit more context. I'm happy to go without the slides. Dare I say there's nothing incredibly insightful on them, but we can share them around afterwards for those online, those in the room. Very happy to make them public. So the bit of context I was going to get into is that a couple of months ago hang on, IT's in the room. We're on pause again.
You could tell us how come CSIRO is interested in the social, in our case, the social determinants. How did you come to that? Or were you going to say that anyhow?
I wasn't going to say it, and I don't know that I'm the best person to answer it, but I suspect that we've been involved in it for a long time in some way, shape or form. Because 20% only about 20% of an individual's health is influenced by clinical care. So, as far as R&D goes, it's probably still skewed towards clinical care because that's what modern science is founded on. But we're entering this next generation where there's a lot of research getting up and underway around lifestyle and behaviour change and socioeconomic support and all the other things that really need to come together to create a more holistic approach to health and wellbeing. Thank you, IT. Does that broadly answer the question? So, in short, I think we've always been doing it, but how we've been doing it might be.
You said the sciences with you, but then you talked about lifestyle and something else. Those ain't necessarily, depends how we understand lifestyle. That isn't necessarily a social determinant. I mean, doing jogging around the harbour, that's good for you, but that's not. Lifestyle and social determinants can be distinguished one from the other. They're related, but
yeah, they can. I think that'd be overlapping too if you're in a club that jogs together. So yeah, it was more that there's a bunch of things that make up that 80% I was talking about. The environment's another big one, and R&D has traditionally focused more so on the latest technology, which is absolutely a part of unlocking some of this. But there are a lot of softer skills and policies and whatnot that CSIRO shouldn't get involved in all of it because we are an R&D organisation, but there's certainly R&D behind a lot of that 80% that maybe 20, 30 years ago we weren't looking at because it wasn't on the agenda.
And who's listening?
Well, we report directly to the government. The Department of Industry is our governing department.
You see a change in government, like the Department of Health. You see them changing their policies and practice according to the information you're giving them?
That's a difficult, causality is difficult. That would be listening to a lot of people and making decisions, and to claim that they made one because of something we said to them is not something I can comment on. That's certainly a key stakeholder in the report that I was about to mention. So we spoke a lot to them in terms of consultation, but now that it's there, they've thanked us for it, and they seem to be considering it. But this is 2 months ago, and government don't work at that kind of urgency. Elections coming up, so. Yeah, I think this is one of those things where one project alone is not going to break a camel's back, but it's adding to the weight of not just paper but conversations that are occurring around certain topics, and showing that there's some momentum behind certain things. Yeah.
I could ask Alan, if you're ready to go ahead.
I'll get going, and then I think there's time after this presentation, which will be about another 20 minutes or so, to turn this more into a group discussion where people put their thoughts forward and object to ideas that I might present here or agree with them, and get into the next level of detail. So let's try and hit next again. Excellent. So this is the report that I was referring to. We released it a couple of months ago in conjunction with our health and biosecurity research area, titled Future of Health. It's the output of a largely consultative process. So to develop this, we spoke with GPs, we spoke with service providers, insurers in the health space, banks, educators, researchers, other areas of industry, and government that was discussed. And the broad theme of it and those conversations was discussing how we can transition to a more preventative, precision-based and proactive approach to health and wellbeing in Australia. In fact, some of the organisations on this alliance were part of the list that we consulted with. Yes, the report does commence by summarising the challenges within Australia, including the much discussed sustainable financing and the fact that we're all getting older and chronic disease exploding, other things around equity and digital literacy and trust and consumer behaviour discussed there too. But we wanted to note the challenges and write about them fairly concisely so that we could move into what's a more aspirational future that we're trying to head towards, and how do we get there. So that's what the bulk of the material in this report relates to. Things about empowering consumers and unlocking the value of digitised data, preparing future clinicians, but supporting integrated and precision health solutions, and how we can better integrate with the global sector, given that health really, well, it already is a global sector, and it's increasingly being felt that way. But for today, I've been asked to focus on the findings of the report that relate to equity, if your glass half full, or in this case, inequity. So inequities exist across a range of social, economic, cultural measures, and they cost Australia almost $230 billion a year. That's more than mental illness and obesity, which it feels a lot of the time are more discussed. Groups facing inequitable health outcomes include Aboriginal and Torres Strait Islander people, homeless people, those affected by chronic illness and disability, and their carers, unemployed people, or those in unsecure, low-paid environments and employments, people living in remote areas, so in immigrant populations. So it comes in a lot of different forms. What's more is, then in addition to helping all of those people have better health outcomes, there's a hell of a lot of benefit that's been estimated to be realised if we address some of those issues. We found in our consultations and through some preliminary analysis that shifting those with inequitable health outcomes up the health curve provides not just social but greater economic returns than simply extending the lifespan of those in more advantaged populations. I won't go through everything there, but as you can see, there's 500,000 avoiding chronic disease potentially, fewer hospital admissions, but also economic returns. So there's, even in those few stats there's billions of dollars of savings there in a context where sustainable financing of health is a really big issue. I suspect I'm preaching to the converted in terms of how important this stuff is, so I won't go into any more detail on that. Instead, I'll try and get to some themes of the report that speak to how we can start to shift to addressing inequity. And again, it's not going to cover every specific interest that's represented in this room and online, but hopefully it's a start and we can continue that in a group discussion. So there's a few themes that I've broken down the following slides into, and the first is digital health solutions. Will digital health solutions be the great equaliser, or are they just going to add to greater inequality. Brett and I were discussing this briefly in the lead up to today, and we both broadly shared the view, I think, keeping honest here, that those who are most in need or can most benefit from digital health solutions are probably those that are least likely to be able to engage with them and use them due to having the lowest digital health literacy. We've got apps, we've got artificial intelligence, we've got virtual reality, augmented reality, bots, you name it, and it's growing. And so digital literacy is essential for delivering but also receiving the best support, the best healthcare support. So I haven't seen a comprehensive analysis of digital literacy in Australia, but what I have seen doesn't paint a particularly strong picture. About 40% of both Year 6 and Year 10 students have failed to meet proficient standard ICT literacy. And on top of that, 60% of Australians have an inadequate level of health literacy. So certainly some room to grow there. I think we need to be really clear about who the enemy is here. It's not digital health solutions. They still very much hold the power to realise step change increases in Australia's overall health outcomes. It's the low levels of digital health literacy, digital and health literacy that we need to tackle. So there's a few examples there, which you can't see the screen, that I've listed out, and each of the following themes and slides will have some examples. I won't go through each of them. They're all in the report and discussed in a bit more detail there, but perhaps just to give some examples. So the first one there, develop tailored incentives for engagement in personal health and wellbeing. The tailored word there is the key one there. Whether it's an app or a telehealth service, whatever it is, a digital health service, often in order to get those with inequitable health outcomes to engage with them, you need to provide some form of incentive. In my opinion, it's a little bit lazy just to provide that as a bit of cash right up front. It's certainly attractive and will get them to engage in it, but how they spend that money without associated education might be on cigarettes or fast food for their family, right? So the types of incentives need to be carefully considered based on the population you're trying to target. As an example, remote or regional communities often have very little access to internet, or it can be very expensive in those regions. Instead of a cash outlay, why not provide access to free internet, or why not provide food coupons to a place where you can only purchase healthy food from? So it's not just the tool that you're trying to get them engaged in using that provides some kind of health or digital literacy improvement, but it's actually the incentive as well that adds to that impact. Another example there is artificial intelligence-backed digital health tools. It's really easy for the companies that make these types of platforms to target the masses because they're a business and that's predominantly where the money is. That makes sense. The laziness comes in when you try and repurpose that amazing tool and replicate the amazing outcomes in a population-facing inequitable health outcomes, because the data trained to create that machine learning algorithm was used most typically with the masses in mind. And so the recruitment process for that involved people from a population that is not the same population you would then be trying to apply to, and so you can't expect the same outcome. So while it is a bit of extra effort, one of the recommendations here is to make sure that these businesses and organisations really go back to the research phase when they're trying to apply these tools to a new population. So the next theme here is in empowering consumers. And one of the broad themes of this report is really that consumers are an underutilised resource in health. A lot of people find it really hard to know at what point their health transitions from a level where they can effectively manage it themselves, be it through diet or lifestyle behaviour changes, maybe available DIY services, to needing to seek guidance from a certified health professional. And of those of us who can figure out roughly where we are on that spectrum, if we're in the self-managed space, not all of us know how to go about accessing those self-management tools. And if we do feel the need to go and visit a certified clinician, it can be really hard to assess the quality of the service you get. And both of those issues come down to the high levels of information asymmetry in the health sector. And so those first few examples there largely relate to addressing the information asymmetry gap in health. As an example, that first one there is a consumer rating tool, which I'm personally a big fan of, and we're seeing more and more of already, and they're getting more sophisticated. to play devil's advocate, I've got a fairly pessimistic colleague in my team who actually thinks that consumer rating tools are going to lead to greater inequity. Does anybody want to have a stab at why they think that may be the case?
One would guess that the tool has been given to those people who access already. Surely our interest is partly in people who don't access. So you're going to get a very skewed rating, no?
You're spot on, and that's not what was in my head as the correct answer, but that's absolutely another reason that it could lead to inequity, yeah, if they don't have the personal skills to access a consumer rating tool like this, absolutely. My colleague thinks, and I think the logic checks out, if there's complete transparency or near complete transparency, be it over quality or price, then the better doctors, and there will always be better and worse doctors. Any population, 50% are going to be above average, right? Doesn't mean they're bad. The better doctors will be known. They can therefore charge more. People with more money will go to them, and all of a sudden, you start to see this divide growing. You take it a step further, you might even find clinicians locating in wealthier areas so that they get the clients that want to go to them, less sophisticated health problems maybe. So it's pessimistic. I think the rationale is right. I also think there's probably enough things that government can do to mitigate those types of risks, and it's still probably a better scenario than where we find ourselves presently. But perhaps that's a topic you might want to pick up, particularly with clinicians in the room, in a discussion after this presentation. What else have we got there? Yeah, telehealth services, completely underutilised. I won't spend too much more time on that, but we're big fans of, not just in terms of increasing access to people in remote areas, but it's financially solid, this idea, right? Whether you're using it as a pre-screening or you need to get a referral, you don't want to go and drive all the way just to get that. There's a lot of services provided that don't need face-to-face interaction. Although our vision does absolutely say that face-to-face and human interactions are a critical part of care in the future, there are a few areas where telehealth services are really, really useful. The fourth theme is a specific group facing inequitable health outcomes, Aboriginal and Torres Strait Islander peoples. We don't break out every group I mentioned earlier in the report, but this was a theme that came up again and again across basically all types of stakeholders we consult from across the sector. So compared to non-Indigenous Australians, we see estimates of 10-year life expectancy gaps, high child mortality, high rates of chronic disease, high rates of hospitalisation. One risk in a report like this, and even in a presentation like this, is that we treat all Aboriginal and Torres Strait Islanders as a single group, which is of course not the case. There's a great deal of diversity. So we try to make it clear that the solutions you do develop for these populations really do take into consideration the diversity and the specific community you're tailoring the solution to. However, there are a few things that did feel like they came across as cross-cutting. This pie chart may or may not be cross-cutting, but it's here to highlight that nowhere near enough is known about why this inequity exists or the actual detail of it. You can see there the largest slice of the pie is other factors. And a lot of that is access, but even this piece of analysis couldn't break it down completely. And the other area we just don't know enough about is what initiatives work best within the diversity of each of these communities. So a lot of the actions that we put forward in the report in this space are actually just to better understand the problem. It's been a problem for a very, very long time, so it's somewhat startling that compared to maybe some of the other health issues in Australia, we still know relatively little about the underlying causes.
Sorry, could you just, I'm surprised of that. I thought we knew a hell of a lot about these other factors, Aboriginal, but we're not just talking about remote people, we're talking about the majority of Aboriginal people who live along the road in Western Sydney or Western. What do you mean by we don't know?
Well, if you go, I can give you the source of this later, but if you go into this analysis like it, that we know enough to segment that pie as it's presented there, but unpacking what percentage of that is about access issues, and I'm right with you right there. We often talk about Indigenous populations.
From the Aboriginal website, how they would put together what's on your left and what's on the right. I think they would link the health gap and the social determinants very closely. Am I right?
I think you're right.
The problem is, as you already said, there are too many players with too many theories and too many analyses. So it's on that particular day who's talking is where the meeting goes, unfortunately. So what he's saying is that if you sit in an Aboriginal group who have got their own data, they will totally disagree with you. But then you can't then, it's like two religions. So the databases we are dealing with are too many around. And honestly, what he's saying is, we live in rural towns and half of what you say doesn't apply. But then we have to have a policy from top down. So we are compromising to get one policy top down. We compromise a lot of truth at that grassroots level. And that's life. I'm not saying there's an answer, but I think that sort of is what he's saying and what you're saying. Not everybody will agree with everything. And there are people argue that 85% is social determinants or 90%.
And some of those social determinants are historical, intergenerational trauma, mentioning the social stolen generation, etc. That the context of Aboriginal people's lives is surely
it's very complicated too.
But it has a historical element which is well documented and surely must feature somewhere.
It would be interesting to see the research that was based on.
Happy to share. And I completely agree with you. A lot is known about the types of reasons for the health gap. The point I'm making is, in order to tailor solutions to communities, you need to know what are the proportions of each of those 100, right? There's so many reasons why that exists, and we know what they are, but we don't know roughly how much each is contributing to the health outcomes. We just know that collectively, this group of activities over generations has led to this.
I think for me, one of the interesting questions with this is what we include in social determinants and what might in this perhaps exist in this other sphere, what would be described as sort of cultural determinants and, social context and colonisation history and all of that, and how that interplays with models of care and access to all of. I think what he's saying is that there is a well understood range of things that are impacting individuals' health. What we're perhaps not, or perhaps we should say what the mainstream system is not yet able to appropriately articulate, is how to link that to improvements in access and care and all of those things.
Thank you.
That would be my interpretation.
I think
I want to echo that.
Articulate. Yeah. So there's a few points there around improving that and better understanding that. The co-creation of health solutions is really just a no-brainer, but it's surprising that it doesn't always happen. And that doesn't need to necessarily be with elders of the community, although that is often the first place to start. But there are other key influences, be it celebrities that have been raised in that area and have a real pull and idol status to them in the community, or other younger influences. But it just doesn't make sense to create health solutions without engagement for those cultural considerations. The one at the bottom is an interesting one, in that I think there's benefits both ways. So, as you were saying, John, stolen generation, a lot of these communities have been displaced from the country that they connect to, right? And that's got a really significant impact on mental well-being, family, social structures. And in some cases, they've been reunited with their family, but not in their country. So absolutely getting them back on their country, but also, and when I said there's a mutual benefit here, I think there's a lot that these communities can teach, more Western medicine and non-Indigenous Australians about how to sustainably engage in the environment and the social and mental wellbeing benefits of engaging in the environment.
So there's a Nacho releases they do very regularly, and there's a big study happening to investigate that and measure it if they can.
Yeah, wow, that would be impressive. Yeah. Do you know when that's due for?
I think it's just been announced that they're doing the study, so I guess it was going to be probably a year or two before we get the results.
Yeah, interesting stuff. And so the final theme from the report that I thought was somewhat related to addressing this inequity topic is preparing a future health clinician or health professional. And this section of the report's a lot bigger than these 4 points suggest, but I tried to just pull a few areas where it actually really clearly ties back to the topic of equity. So greater training we think is needed around equity, ethics and the different cultural norms and healthcare needs of diverse populations and cultures, because these different cultures have different beliefs about how data should be handled, who should have access to it, whether it should be collected in the first place, who it should be shared with, if at all. The incorporation of empathy into communication was another theme that arose fairly strongly. It's been linked with improved patient satisfaction and health outcomes, as well as reduced physician burnout. And the third element where we got a lot of input was on, going back, I guess, tying into the digital health solutions, in that as more and more digital health solutions come to market, GPs, for example, are absolutely going to have to get across the latest in the data streams that are coming to them, for example, wearables, and how to understand that data and use it in their consults and use it in their diagnostics. The risk there is that the GPs or the health professionals, whoever it might be, move with the times but forget about the populations facing inequitable health outcomes who don't engage with those tools. So keeping abreast of the latest in face-to-face consultations and how to best provide support to those populations that aren't coming with all this data already is something that they're going to have to balance, and it's not going to be easy, because it's more work, not less. I guess the action from a lot of the content in our report around this is firstly to incorporate a lot of these topics more so into tertiary education and grade on it. Not just have a token course on ethics or equity, but grade based on it. And the second being to build into recruitment. So it's all very well to try and do your best to train future clinicians in this space, but to hold industry accountable and saying, if you're not demonstrating these types of skills, you're not the type of person we want employed. There are 4 themes, and there's so many more, it's not funny, but there are 4 that probably we cover the most in our report that wasn't targeted specifically at equity issues. All of the ideas I've presented and that are in the report require additional investment. They require this investment in a context where government or private insurer or even personal investment is often feels like it's declining, certainly under a lot of pressure. So it's important to divest away from low value care in order to free up funds for this kind of stuff. There are some clear examples of low value care, and again, I think the clinicians may have some interesting perspectives on that. Personally, I think there's a lot of avoidable surgeries like knee arthroscopies, overuse of antibiotics, but there still needs to be a lot of effort put into measuring value and figuring out what we mean by low value care, so that we can in a more targeted way advocate to government, saying we think this is the area where we're not getting high outcomes for spend and we should divest away from. So I guess the final message I'll leave the presentation on is that if you are advocating for something, it needs to be a more complete solution than we think we need more effort in this space. If you can go even partly towards how funds can be freed up, how that might be funded, who needs to be involved, what is the role of each of those organisations, you can make it a lot easier for the decision maker to make the decision that you want to make. So on that, that's all I had, but I think there's now a plan to maybe turn it into more of a group discussion.
Absolutely.
Yeah, but other than that, thanks very much for your time.
Oh, thank you.
Thank you very much.
Great.